sir, for joining with us. Also, we have one more special speaker with us, Dr. Prashant Ingon. And sir has completed the MBBS as well as the MS obstetric as well as the gynecology and in the Gwalior. Presently, like a post, he was the assistant professor for the Varudi and district of the Jalna. And he has a private practice in the periphery and test tube baby sonography. Also, his special, like he has a passion in teaching and training experiences. One main thing, actually, he has trained over more than 75 postgraduates. That's really nice to hear that, sir. And I will hand over to the Dr. Aniruddha, sir. And thank you.
Thank you for that wonderful introduction, John. This edition we don't have our regular favorite Dr. Mahesh Tandale, who is our the really dear one to share his thoughts on the entire process of the sessions altogether. Dr. Prashant Ingole is very good friend of mine. That's first thing, and secondly, again, in a common indicator is that. Dr. Tandale has given a good replacement because Dr. Prashant Ingole and myself both are great fan of Dr. Mahesh Tandale. So I think Dr. Prashant Ingole will be throwing good insight about most of the things pertaining to the cervical insufficiency in next 1 hour or so. So today's plan is that, can I share my screen, please?
Yes, sir.
Okay.
We are able to see your slides, sir.
I think you will be able to see my slides.
Yes.
The next thing is that I will just minimize it. Okay. And play.
Perfect, sir.
Hope it is full screen.
Yes, sir. It is a full screen.
Okay. So thank you very much. Standard acknowledgement disclosures from my end. Ultrasound medicine videos belongs to my center. Clinical cases in association with referring physician, text and references duly acknowledged. Content has been specially designed for Scholar MD. No copyright dispute. The highlight of today's session is scanning technique and protocol, technique and tips in assessment of cervical insufficiency, and some of the key features. Cervical morphology in early pregnancy, mid trimester, and late third trimester, particularly related to the pregnancy preterm deliveries. Cervical insufficiency imaging, insufficiency to predict preterm labor or preterm births, regarding which some of the very important clinical insight and surveillance protocols will be shared by Dr. Prashant Ingole. I will just say a few lines about elastography and role of MR. The function of cervix during pregnancy is it acts as a barrier for microbes, do not allow it to ascend to the pregnancy. It holds the pregnancy. It allows easy passage of the fetus during the labor by effective dilatation. It is expected to remain closed throughout the pregnancy till it reaches its desired destination in terms of delivery during parturition. We all must understand, and Dr. Prashant Ingole also will agree and emphasize that transvaginal ultrasound is always and always gold standard in all situations. Now, all those images which you see here, definitely there is a dilatation of the cervix along with funneling of the membrane. But all these images are transabdominal images. And we are not happy with transabdominal images, neither with translabial images. We have to perform transvaginal ultrasound in each and every patient, normal or abnormal, where the internal os and cervix is to be assessed. So, transvaginal ultrasound is always gold standard, whether the patient is having bleeding PV, whether the patient is having inevitable miscarriage, whether the patient is having placenta previa. Transvaginal ultrasound is always and always gold standard. Never ever try and miss out transvaginal ultrasound just because the patient is not allowing. In case of a non-pregnant assessment of cervical length or cervix, we always say that the cervix is hypoechoic, is more or less equally placed on both the side. We can identify the anatomical internal os because the endometrial cavity pinpoints to a pinpoint junction where it enters into cervical canal. That's the anatomical internal os. That's the internal os and that's the cervical length, which really is corresponding to this is the uterine cavity. It corresponds to this juncture on 3D acquisition of the data. So we should habituate ourselves to identify the normal internal os in a non-pregnant state as well. In case of early pregnancy assessment, nobody will ask specifically about the status of the cervical canal, but at the same time, we need to understand that there are so many signs and features related to the internal and cervical canal, which can give additional information related to the pregnancy status. Like we don't call nowadays inevitable abortion. Abortion is the terminology when the patient opts for it. If it's without patient consent, we call it as a miscarriage. So inevitable miscarriage, non-viable pregnancies, where you can identify sac separation with a bleeding zone adjacent to the internal os, where trickling of fluid into the cervical canal can be easily identified. Not only that, we have seen in few of our sessions, I think we have conducted on low implantation of sac and its subsequent analytical approach. Because the number of cesarean scar nowadays are on rise, the incidence of cervical ectopic pregnancy as well as the cesarean scar pregnancies are on rise. The patient where embryo transfer is done, again, the cervical pregnancies also are on rise. In case of early pregnancy, what we say is that internal os is closed, cervical length is normal, no evidence of fluid within the cervical canal. The gestational sac is away from the internal os if it is upper implantation, or gestational sac is in close relation to internal os if it's a low implantation. What does the low implantation really means is that when the lower tropoplastic margin of the gestational sac is less than 5 centimeter from the external os that we have seen in our earlier talk. So how do we differentiate various gestational sacs or products related to internal os? That is the cesarean scar pregnancy, cervical stage of miscarriage, or precursor of morbidly adherent placenta in due course of time. Now, when the placentation or gestation sac implantation occurs very close to the internal os, that's a low implantation, it may produce bleeding PV or pain, or there can be additionally a caesarean scar adjoining to it. So we say it's a low implantation sac. So whenever it's a low implantation sac, look for periplastic flow. If it is absent, the sliding is positive. It can be cervical stage of miscarriage. If the sliding sign is negative, we look for three features. The gestational sac in cervical myometrium, that's a cervical pregnancy. Gestational sac within the deficient myometrium less than 5 millimeter, that's caesarean scar pregnancy, or cervico-ischemic implantation, wherein there are history of multiple scar. You can apply cost criteria on transvaginal scan and say that this likely, if it continues, can cause a morbidly adherent placenta in due course of time. In case of a cervical stage of miscarriage, products or sac which is detached from the fundus, which is non-viable, will be seen in the cervical canal, where cervical canal will be ballooned and it will be held up by the external os. There will not be any peritropoplastic flow. Now look at these senior lobes. Here you can see that the prolapsing gestational sac is visualized where the internal os is completely open. You can see that there is some amount of flow within the gestational sac, but very minimal amount of flow adjoining to that. That's a cervical stage of miscarriage. Now here there are two senior lobes. Here obviously you are not able to see anything beyond a gestational sac over there. Here you can see gestational sac along with the yolk sac. And In here, as my transducer is getting advanced, you can see that it is absolutely just adjacent to the external os over there. So not only that, if I try to elicit the sliding sign, I can say that there is a peritoneal activity, there is an oblong shape of the gestational sac. Not only that, there is some amount of gestational sac which is extending into the intrauterine cavity. So I am sure that it is nothing but a cervical stage of miscarriage. Just to add on to that, the moment you do a 3D ultrasound, you can say that yes, here the internal os is open, the cavity is empty, minimal amount of sac, which is oblong in nature, is seen in the within the cavity, and predominantly the sac is seen in the cervical canal along with the embryo, which do not show any activity over there. In case of a post miscarriage, on many instances, you will see that there is a minimal amount of fluid. This is a retroverted uterus. There is a minimal amount of fluid within the cavity, and that fluid is not only seen within the cavity, it is trickling down with the os which is looks to be open, and I can see that the same fluid track is seen within the cervical canal. This is nothing but a post miscarriage, a cervical canal fluid collection. On many instances, you might feel that here it's completely at the level of introitus. I can see that there is a chorionic activity, chorionic tissue within the cavity. The gestational sac is collapsed there, and I can see that the entire back of membrane is seen at the level of introitus, which is covered by the membrane. Which obviously, now here you can see this is the internal os, that's the cervical canal, that's the external cervix, and you can see that it's in the vaginal introitus rather than within the cavity over there. What are the changes that occurs in the cervix during the pregnancy? Cervical shortening, internal os should be closed till the labor. The collagen and the elasticity will subsequently change as the patient reaches the mid trimester, second trimester, and the late third trimester. The myometrial apparent thinning will occur within the cervical canal as well. Here you can see that the internal os is closed, cervical length is normal. As it's a term pregnancy, here you can see there is a minimal opening of the internal os with cervical shortening. For years together, when we used to say that when the cervical rounding mound is noted at the level of internal os, more or less we are happy with the cervical status as well as the internal os. But now we have decided that these additional mounds which we get may not be a feature of integrity of internal os, because on many instances there can be a persistent uterine contraction in second trimester which is responsible for such mounds. What is a typical transvaginal protocol for assessment of internal os and cervix? The bladder should be empty or it should be minimally distended. The transducer should be in anterior fornix. Sagittal cervical mucosa demonstrating the entire length of endocervix in the form of length of external os to internal os should be visualized. We should evaluate the entire cervix for 5 minutes or more. On many instances, the probe pressure can be more. So withdraw the probe until you see little bit of blur. And then again you reinsert the probe to get a sharper image and to reduce and adjust the pressure so that the anterior lip of cervix is not compressed. At least 2/3 of the screen should be occupied by the cervix, the same way in which we do the typical NTs of this time. So zoom and depth should be adjusted. Take 3 measurements of external os to internal os to endocervical canal, and the shortest measurement possible should be measured. Apply gentle transfundal pressure by your left hand for 15 seconds. And again, retake the measurement of the cervical length and take these 2 measurements, regarding which I will explain in one of the slides. So there is a site which is called clear.perinatalquality.org. In between, it was not functional. Recent update, I don't have any idea whether it's functional or not. It says it's a cervical length educational review, which describes how do you take the cervical assessment in mid trimester. You can measure the cervical length by end to end or what you can say, a multi-step approach by taking it rather than a trace method. So the anterior lip of the cervix should be equal to the posterior lip. The entire cervical canal should be visualized. The internal os should be flat or isosceal. The shortest three base measurements should be taken into consideration. Let us take this example. Now look at the screen per se. The entire skin, more than two-thirds, is occupied by the cervical canal. Secondly, I am trying to adjust the probe pressure where my transducer is in the anterior fornix. I can see the external cervical opening here. That's the external os. That's the posterior lips. That's the anterior lip. And that's the endocervical canal. And this is the mounts at the level of internal os. So the anterior lip is equal to posterior lip. The optimal criteria. Now I am increasing the pressure. You can see the cervical length is increasing. The moment I am releasing the pressure, I am adjusting the anterior and posterior lip. You can see now when it's equal, the cervical length appears to be normal and internal os is closed. So this technique is very, very important. And we should practice this technique in cases of patients who are non-symptomatic. That is, those patients who are not for preterm labor surveillance, or those patients who are not surveillance or not put for surveillance for assessment of internal and cervix for risk of preterm labor. So that in case of indicated patient, we can do it in a fair job fashion. Now, when you assess the cervix, the first thing that you assess is funneling length when the internal os is open. That means we calculate the width of at the level of internal os. The next one is the funneling percentage. So funneling length, effective cervical length, total cervical length, that is A plus B, and the width. And then we calculate the funneling percentage as A is a funneling length and B is a cervical effective length, and A plus B is a total cervical length. So A upon A plus B is a funneling percentage. The real meaning of funneling length is nothing but the remaining portion of the cervix where the closed portion of endocervical mucosa is not seen. This is the closed portion of the endocervical canal. This is the closed portion of the endocervical canal. So this is the width at the level of internal os. This is the funneling length. This is effective cervical length. So this is B. This is A. So what we are going to calculate is A upon A plus B. This is A plus B. Why does the pressure is so much important? Take example in this case. I have put in more pressure through the anterior fornix. The anterior cervical epidiameter is less than the posterior one. The moment I release the pressure, now you can appreciate that the internal os is in fact open. Here, you can see that the cervical length appears to be normal. Now, there is a cervical shortening here. So, the foremost criteria is always assess the mid-trimesteric internal os and cervical length assessment by a classical protocol of doing the transvaginal ultrasound. So, this is the internal os, this is internal os diameter. This is length of the funnel. This is functional length of the cervical canal. And this is total length of the cervical canal. So, A upon A plus B. One more criteria, uterocervical angle. So, this is uterocervical angle. So, increasingly wide uterocervical angle after mid-trimestral encerclage is key for surveillance. A wide uterocervical angle, which is more than 95 or more than 105 degree, detects during second trimester, was associated with increased risk for spontaneous preterm labor in less than 37 or less than 34 weeks respectively. A combination of uterocervical angle along with cervical length can act as a better predictor of preterm labor. I'm not going to speak much about preterm labor or preterm labor birth surveillance criteria because some of the important key features will be described by Dr. Prashant Ingole. One more index, that's a cervical, that is CCI index, which measures the AP diameters. So measure the cervix in anteroposterior diameter. Then we apply the probe pressure over the cervix and we measure the cervix cervical length again. So this length is AP. This length, let us assume AP dash or APA. So AP dash upon APA into 100 is a percentage. Okay. So this quantifies the cervical softening, which is a key sign of cervical remodeling during pregnancy that can precede the shortening. A lower CCI indicates a softer cervix, which is more compressible cervix 1. So cervical consistency index or a CCI is a newer concept, not newer, maybe around last decade or say. So here that's the anteroposterior diameter, that's the anteroposterior diameter posterior lip, that's the cervical length, that's the endocervical canal. So we are going to measure this without application of pressure or with application of pressure. So this is without application of pressure where the anterior and posterior lip of cervix are equal. Here, with application of pressure, this anterior lip of cervix is reduced, posterior lip of cervix is also reduced, but to a lesser extent. So we take into account the cervical length of the both, which in turn says apparent increase in the cervical length because of the pressure, but we are not interested in CCI at this juncture of time. But we take a AP diameter without pressure with equal AP diameter of anterior and posterior lips. And after application of the pressure, the AP diameter of anterior and posterior lip of the cervix. So final step is AP dash upon AP into 100. That's the CCI. That's a cervical consistency index. In case of a non-pregnant status, it is almost more than 80%. And in the first trimester, it is closer to 75, second trimester 68, third trimester 49. But whenever we say that it is less than 65%, the probability of preterm labor is high in contrast to cases where it is more than 65%, where the preterm labor is only 7. Okay. In total 307 cases. So in all, we can say that 65% can be taken as a cutoff value. And it's not going to say that we prevent the preterm labor, but definitely the risk factor can be assessed with that. If you look at the sensitivity and specificity, it's still in good more than 75 to 80% of the level. There are a few more cases which were conducted where again the cutoff values of optimal cervical consistency index are closer to 60%. And the study which I have shown you has shown that 65% cutoff was taken. From ACOG optimal guidelines, cervical insufficiency really means the inability of uterine cervix to retain the pregnancy in absence of a signs and symptoms of clinical contractions or labor, or both in second or late third trimester. The painless cervical dilatation, which is responsible for recurrent pregnancy loss or preterm birth in case of otherwise normal pregnancy which do not have any malformations. Isolated cervical length shortening may not be sufficient enough for the diagnosis. Cervical insufficiency leads to shortening of the cervical length along with gaping of internal os, where we used to believe on the shape, that's a T, Y, V, and U, with membranes protruding into the cervical canal. On many occasions, fetal parts along or the cord can be seen within cervical canal vagina. And few people believe in fetal fibronectin stage testing as well. So here you can see the cervical length is adequate. It's reducing, which is responsible for changing of the shape from T, ballooning Y, aggressive ballooning V, and exceptional ballooning leading to U with reduced effective cervical length. What are the risk factors responsible for the cervical shortening? It could be collagen abnormalities, it could be uterine anomalies, it could be exposure to DES, it could be repeated obstetric trauma or mechanical dilatation. There can be variation in terms of 10th and 19th percentile in terms of cervical length, which is 25 and 45, accepted by more or less. So when we say it's less than 25, we say it's abnormal. So what is important? Important is prior successful outcome after encerclage in that pregnancy or prior unsuccessful outcome after the encerclage. In patients where the internos is open, the width is 4 millimeter or more, the cervical shortening is 25 millimeter or less, and there is a funneling with a funneling percentage that we calculate. Not only that, we calculate the CCI. Ultrasound close surveillance is very important whenever there is a prior unsuccessful outcome after the encerclage. Coming to preterm death, few slides on that. Two-third majority are spontaneous and recurrent. The risk is very high. History of previous spontaneous preterm birth is strongest risk predictor. Usually the screening tool is the transvaginal assessment of cervical length in between 16 to 24 weeks. When we say it's a short cervix, by mere terminology, it doesn't mean that it is in between 20 to 30 millimeter. It always means it is less than 25 millimeter with funneling at the level of internal os. There are two categories of the woman. Women with previous preterm birth, which do not have a shortened cervix at that period of time. And the second group is women with previous preterm birth with a normal cervical length at that time. Now, those who have a shorter length at that period of time or a normal length, the maximum risk of population is that presently they do not have any short cervix and previous history shows a previous preterm birth. Cervical stress test, which is again a combination of assessment of cervical length and manual pressure, where in between 16 to 24 weeks, a transfundal sustained pressure is given and we monitor the changes in cervical length without pressure and with pressure. And if there is a dilatation at the level of internal os, then we monitor the dilatation at the level of internal os along with the funneling length. There are certain pitfalls which are very important. That's the precise reason why we always emphasize for transvaginal assessment is that whenever the bladder is full or over distended, there is going to be a cervical elongation and false appearance of a cervical elongation or loss of the diagnostic criteria where the internos may be open. Okay. Now, again, on many instances, the internos may be dilated. There may be fluid within the canal and the membrane will be closed. Here it will be dilated, but the moment you give a pressure, it will be obliterated. On many instances, you will see that the internos is closed. There are hypoechoic areas within the canal, but there can be interrupted membrane within the same. That's a pseudo-dilatation. That's the appearance of a minimal fluid or hypoechogenicity because of cervical ripening, which is giving rise to pseudo-dilatation. So, these pitfalls should always and always should be taken into consideration. So, over-distended bladder, lack of fundal pressure, vaginal probe compression, or merely coming to a conclusion on transabdominal or translabial scan always can cause a lot of fallacies in your measurements. Cervical insufficiency in terms of funneling index. So here the internos is open. There is a ballooning of membrane. And here you can see a lot of funneling is seen. The effective cervical length is very less. Here you can see that the bladder is partially filled. I can see anterior lip and posterior lip of cervix, which are almost equal to each other. The next step will be identifying the width at the level of internal os in terms of dilatation. The next one is to identify the funneling length. The third one is the effective or a residual cervical length. And then we make a combination of A plus B, and that's the denominator over there. So A upon A plus B is a funneling percentage. Trans-abdominally, there is obviously funneling there. Then you will say that why I am forced to do a transvaginal ultrasound. But always believe that unless and until you do a transvaginal assessment, you will not be able to assess the criteria of intravascular dilatation and effective cervical length in a better fashion. Whenever you do a cervical screening in case of history of previous preterm birth, there are two entities, Society of Fetal Medicine and the ACOG criteria. They say we can do it every 1 or 2 weeks as per the need of clinical indication in between 16 to 24 weeks. In case of a singleton pregnancy with history of previous preterm birth, a routine cervical screening itself will be sufficient enough. Without any previous history of a preterm birth, in each and every patient to screen the intra and cervix is a debatable one. There is no consensus statement on that at present. After the encerclage, there is a progressive cervical shortening where this less than 10 millimeter, even after the encerclage, we can still monitor at 1 to 2 weeks of just 2 week interval. No additional treatment modality is available as on date for the same. There is no consensus statement to follow such cases in cervical screening, but still, I think cervical funneling can be assessed with effective cervical length at 2 weeks interval. Now, this is the encircler stitch. Can you identify the hyperechoic dot with little bit of shadowing over there? That's the place where the encircler has been done. And you can see that the cervix is quite short in this patient. In case of a multiple pregnancy, obviously, cervix can be short and there are again increased chances of PTB. The cervical length assessment will help, but it is not a protocol based unless there is a mandatory parameter in terms of loss of pregnancy at earlier period of gestation. Now, because nowadays the MRI is available at distinct places and below that also. Now, why not use MRI for cervical insufficiency? So there is one article by Rick et al., which says that cervix which is shorter than 30 millimeters, but no, we are not going to accept unless and it is less than 25 millimeter. He also agreed to internal cervical diameter more less than 4 millimeter, thinning and absence of low single intensity cervical stroma. But it is not likely to add to some of your valuable advantage of transvaginal because it's a dynamic, easily available, can be done at the level of labor room as well. This is how the cervix look like on MR. There are few articles which speaks high about elastography, that is imaging analysis of cervical elastography in predicting successful induction of labor, evaluation of cervical stiffness during pregnancy using semi-quantitative analysis, elastography of uterine cervix implications of success of induction of labor. But still as on date, as a primary modality to assess the stage of labor or stage at which labor can be induced is still in the pipeline. The ripening of the cervix, how does it occur? There's a decreased collagen fiber alignment and the strength. There's a diminished tensile length, strength, and extracellular cervical fluid or matrix, increased cervical decorin. This together leads to softening of the cervical canal. Now here you can see that these are images taken from one of the article which I have mentioned you earlier. Here you can see the cervix over there. So this is our area of interest as far as the cervical elastography is concerned. So in terms of a stiffness on cervical elastography, the blue denotes the hard and tough area. The green denotes the firm and the softer area. The red denotes softer areas and loose areas. So more or less, we are more interested in green and red area because as the patient reaches to the term, this greener and softer areas would increase, and that's what we are going to monitor. So here, obviously, there can be differences in the stiffness. Here, a lot of blue areas, which means that we are looking at a harder and tough cervical myometrium adjoining endocervical canal over there, and this endocervical canal is in reddish in nature. But here, in terms of a pre-labor, here you can see that there is a lot of green areas which have appeared within the cervical myometrium, and there is a red area involved in the endocervical canal. So more greener area means more softer area. More red area means more softer and loose area. That means the patient is in the pre-labor. So the term labor on number one on grayscale will appear more hypo in nature with reduced cervical length. Not only that, if you look at the overall vascularity, there will be increased vascularity, which will also will be responsible for more hypo areas on the grayscale. But in case of a active pre-labor or during the labor, the softness will reach to its peak level where the green area or the red area will increase. And that's we are likely to monitor as and when the cervical elastography gains its popularity in terms of quantitative assessment in case of labor. But standard more or less is a Bishop score. Most of obstetrician might know the same. The cervical ripening on MRI, where T2 reaction time does not correlate with the clinical Bishop score, but still it is in the primitive stage. So thank you very much for your patient listening. The entire insistence out of this talk is that don't take internal and cervix lightly during early pregnancy. In cases of patients where they are not put on preterm birth surveillance or previous history of a preterm birth for assessment during mid trimester, for which after anomaly scan it has to be assessed transvaginally. And whenever there is a previous history of a preterm birth or a previous history of encirclage where preterm birth was successful or unsuccessful, in subsequent pregnancy for cervical length assessment, always and always believe on the parameters of transvaginal ultrasound only. Not only that, the cervical consistency index or cervical efficiency scored by funneling index is going to help you to quantify whether the cervix is favorable or not. So thank you very much for your patient listening. Now I'm going to stop my screen share. Okay. So we have today with us Dr. Prashant Ingole with us. Can we have Dr. Prashant Ingole on the screen, please?
Yes, sir, I'm there.
So thank you, Prashant, for rescuing us. We have been working with Dr. Mahesh Tandale for many sessions for Guru Gyan series. So you must have listened to whatever things that I have portrayed during my 30-40 minutes talk on interloss and cervix.
Yes, sir.
No, I want to hear from you as a clinician, because finally what is more important from imaging team is how you complement to the findings of clinical team, or how you aid to the clinical tools on which the effective management is decided. So I want to hear you from few of your clinical perspective from you, and then we will come back to few of the questions in due course of time. You can share your screen, please.
Yes. Sir, thank you very much for the opportunity. And I would like to tell everyone that Dr. Aniruddha Kulkarni sir is my mentor. I have learned so many things from respected Aniruddha sir, and it is his greatness to call me as his friend. But I am very young and very junior to learn numerous things from him. First of all, I am very happy to see all those scripts, very beautiful images that you have shared, sir. First thing, as you rightly told, when we do the sonography, we'll start from early early pregnancy. In early pregnancy also we need to do a good transvaginal scan, and the sonologist or the radiologist who is doing the scan should tell us whether the pregnancy is low-lying pregnancy, whether it is cervical pregnancy, or whether it is cesarean scar ectopic pregnancy. Because such
Doctor,
pregnancies, yes, sir.
uh, are we able to see his screen, or we are able to see only his?
Yes, sir. We are able to see the doctor's screen, sir.
Okay, okay.
Okay,
Sorry,
okay.
sorry. Please go ahead.
So the reporting sonologist should tell us whether it is a cervical ectopic, cesarean scar ectopic, or a corneal pregnancy, or a low implantation gestational sac. Because without that information, if the patient comes to me with bleeding PV, and I immediately post her for termination, and if it is a cesarean scar ectopic, that would be a very big catastrophe because the patient may land up with hysterectomy. So in early pregnancy, as you have aptly told, doing a good transvaginal scan and knowing the location of the pregnancy is very, very important. Plus, in a previous cesarean scar pregnancy, it will also help us to know about the placenta accreta syndrome, which we will see in the later part of the pregnancy. Now, this placenta accreta syndrome, as we have seen your many videos and lectures where you aptly deal with them by just putting in KCL, can prevent a major catastrophe, because operating on a patient with previous cesarean section and with PAS requires around at least 12 to 15 transfusions and a lot of stress. So that looking at the uterus, particularly in the first trimester, and looking at the internal os and the cervix is really helpful. Now, preterm birth is the most important cause of neonatal death. 63% of preterm births are responsible for neonatal deaths. The other causes would be infections, asphyxia, and even in developed countries, most of the neonatal deaths are because of preterm labor. Now, why we are not able to decrease the preterm births in the last 50 years? Because there is no effective screening test, and there is no effective intervention to prevent this complication. And as you aptly said, that cervical assessment during all trimester of pregnancy, may it be early pregnancy during the first trimester NT scan or the anomaly scan, and even in the third trimester, it should be by TVS and TVS only. TVS is the gold standard, as you have said. Also, patients have got false beliefs. Patient may say that it may cause miscarriage, it may cause abortions, it may cause bleeding PV, or it may cause early preterm labor. We need to counsel the patient that the assessment of the cervix is incomplete without doing a transvaginal scan. And as a clinician, I would only like to know the effective cervical length, or what you can say the functional length of the cervix, plus percentage of funneling if it is there. And the cutoff is 25 only. We see many reports where the cervical length is 30 and it is written as short cervix, but no other further information like cervical consistency index or the funneling has been mentioned. Now, let us consider preterm births before 34 weeks. So, one third of them would be iatrogenic and two-thirds are spontaneous. So, in these spontaneous preterm births, women who have got a previous preterm births is only 15%. Rest 85% of the births, preterm births, will happen in women who are either priming or who have got a history of term pregnancy. And by asking the history and focusing only on patients who have got prior preterm births, we are only focusing on 15% of patients. The rest of the major chunk, 84%, we are not catering only. But by doing effective cervical length screening in the in every trimester or at every visit, we would be providing justice to such patients. And I would be very happy to know what is the cervical length, because if the cervical length is short, I can ask the patient to be in surveillance with a good radiologist. And when we can do a charting, we can do 2 weekly charting. And if we notice that the cervical length is becoming shorter, we can keep the patient in loop, and we can become alert, and we can even give steroids to the patient if the patient has crossed 28 weeks, and plan the delivery at a tertiary care center with NICU facilities. Now, as you aptly said, that while monitoring, if I have done a cervical encirclage and I have sent the patient to a sonologist, I should know where the stitch has been put, whether it has been put closer to the interloss or whether it is far away from the interloss. If it is very far away from the interloss, the efficiency of the cervical stitch is less. In that case, if funneling happens, I would know that in the next pregnancy, it would be better to put a stitch closer to the internal os. That may be done vaginally, or if the patient has got multiple episodes of mid-trimester abortions, I would like to prefer and go ahead with a laparoscopic cervical encirclage in such cases. So monitoring in a patient with previous failed cerclage, or monitoring in a patient who has already put on cervical stitch is very important. Now, you also spoke about dynamic test. If there is cervical shortening, if there is previous history of cervical mid-trimester abortion, we would also like to know about the fundal pressure or the cervical stress test and the cervical consistency index. Now, important thing to note that bed rest does not reduce preterm birth, but it will increase stress, thrombosis, and muscle atrophy. So whenever we encounter patient and we all have a belief that we should tell the patient to go and take strict bed rest, but it should not happen. Even during COVID times, also we have seen that bed rest and living at home and not moving causes more problems. Now, in the later part of the pregnancy, uh, when we scan the patient, suppose I have got a patient with previous cesarean section and I want to do an elective section of the patient. So each passing day will increase the outcome of the neonate better if it is given more chance in the uterus. So I would like to measure the cervical, I would like to know the cervical length at 37 weeks. If the cervical length is less than 20 weeks, I would like to plan the LSCS at 38 weeks. Or if it is more than 30 mm, then we would like to do the cesarean section at 40 weeks. So that will prevent some emergencies at night. And more important, the normal elective procedures, they have got less morbidity. So elective procedures can be done and emergency situations can be prevented. There is one more thing that I would like to share. In a term patient also, what we do is we do the cervical assessment and know the cervical length. If the cervical length is more than 30 millimeter, then the chance that the patient may land up in cesarean section if she is a nulliparous woman, or even if she is a multiparous woman, is very high. So cervical length measurement has got numerous uses, as you have aptly told. And plus, in addition, fetal fibronectin was also there. If fetal fibronectin levels are done between 22 to 24 weeks. What is fetal fibronectin? It is a glue that keeps the pregnancy added to the uterus. So if it is less, that means chances of preterm labor are high. If it is more, the chances of preterm labor are less. So levels less than 50 nanograms per ml means the chances of preterm labor are high. So that's all from the clinician that I would like to share on.
Thank you, Prashant. I mean, really great, what you can say, great words of wisdom. It's very important to understand that the final goal all together is patient safety. Dr. Prashant, can you are there, no? I mean, you are not going. So we'll take few
No,
questions.
sir. I'm here only.
Okay, we'll take few questions if you don't mind. I mean, there are, I think I have seen one Q&A over there. There is one question in CCI, which is the AP1 up before applying the pressure or after. See, now, Dr. Meghna Katkar. Okay. See, basically, number one is the you apply the apply a pressure, release the pressure, and after releasing the pressure, the AP and posterior diameter are equal. So that's the stage one, and then you apply pressure again. So you take what is called a AP, and we call it a AP dash. Okay, so it's a AP dash is after applying the pressure. So AP is without the pressure, and the second one is after applying the pressure. That's as simple as that. Sir, fetal fibrin test is done in India. I have no idea. Dr. Prashant, do you have any idea about Fetal
Sir, it is
fibrinogen.
done with some bigger labs, but the cost of the test is a big problem, and the reporting time is a bit prolonged. But with the advantage of of doing a TVS, I think that test has really lost its significance.
There is one. There is one question. Is dear organizer and presenter, many thanks for the invitation. Would I mean there is someone who is asking for the entire presentation as a I am a senior midwife from Ethiopia. My email. You need to contact the organizing team. More or less, I am not for the category of sharing entire presentation because more or less it has so many copyright issues as well as the images and scenario loops belongs to my own place. So I'm not happy with that. But still, you can contact with the Mindray team per se. Sir, in case of a non-pregnant woman, can you show how to differentiate the endocervical canal, internal os and cervical canal again? Um, I think, and most of the time, in case of a non-pregnant status, the intraos and cervical length is of importance when there are multiple scars or it's a cervical stage of miscarriage. So just because I cannot go and run back the presentation again, this is query from Dr. Vishal K. But I would just add on to say just to help you out is that in case of a early pregnancy, whenever there is a embryo demise or a low implantation, just try and see that whether the lower margin of chorionic trophoblastic tissue is in relation with the internal os or not. Just release the pressure and identify the external os on the extreme end. So in which you have to adjust the depth and the zoom to adequate level so that your screen takes both of the identity. But I think you can go back and revisit one of my lecture which is there with Mindray on low implantation sac. Sometimes I see fluid within the cervical canal without internal os being open. What I should report. Dr. Kiran, whenever you see a minimal amount of fluid, the cervical length is absolutely normal. The pressure applied is satisfactory. Anterior and posterior lips are equal to each other. You need not bother because some minimal amount of fluid is absolutely okay. In previous cervical incompetence, how much reduction of the cervix per scan done after 15 days once is it? Dr. Prashant, can you say that in case of a in case of previous incompetence, how much reduction of cervical per scan? I would take it as a how would you approach for the surveillance in
Yeah,
previous cervical
previous
incompetence?
preterm birth.
Yes,
Previous preterm birth, we would like to offer such patients after the completion of the NT scan and double marker test, a cervical encirclage. If the patient is not ready for a cervical encirclage, then we can keep the patient on 2 weekly monitoring. And if we find that there is decrease in the cervical length, then we can go ahead with the encirclage. Or the patient can be simply put on progesterone tablet. 200 milligram natural micronized progesterone can be given, or 17 hydroxy progesterone caproate can also be given 250 milligram weekly to the patient. But even if we are giving them progesterone, we have to keep them into surveillance. And if the length goes down less than 25 millimeter as per the cutoff, because this previous preterm birth patient has now got a normal cervical length, or if the patient cervical length is more, say if it is 35 and I notice that has been a change of more than 3 millimeters. Say now in 2 weeks time, the cervical length has gone down to from 35 millimeters to 30 millimeter or to 25 millimeter. Then I would counsel the patient to immediately go in for a cervical encirclage, because the process of mid trimester loss can happen, and to prevent that, we need to do and go ahead with the cervical encirclage. So serial monitoring, basically serial monitoring of such patients is important. And even after doing an encirclage, I would like to know whether there has been some funneling, and to put the patient onto good surveillance.
that's great. Someone has asked, total bed rest is not needed, but how much work and mobility can be allowed?
Household work, we usually tell them people who are doing household works can go ahead and do a household work, and people who are working in sedentary offices can go to offices and work. We ask them not to go and do some extra physical work, like avoid going to the gym, avoid going for trekking, and like that.
Okay. Objective criteria for low-lying sac, there is no object, there is this specific criteria. Lower margin of tropoplastic reaction less than 5 centimeter from external loss. That's very clear, Dr. Abhijit. Okay. Sometimes I see fluid. This I have done with. Okay. Uh, in previous, this I have done with. In previous two preterm deliveries, is it advisable to do chirurgical encephalitis or lap encephalitis?
Now, such patient who has got history of previous preterm births, I would also like to know ki previously was she given a cervical stitch, yes or no? Was she on medical management or surgical management? And if the previous cervical stitch was McDonald's, say, then it would be better to go ahead with a chirurgical stitch. And what were the sonography findings in the previous pregnancies? Whether there was funneling with McDonald's stitch or whether there was some problem with the chirurgical stitch. Actually, if the cervical stitch is closer to the internal os, the better the probability that this cervical stitch will act very nicely. But if it is farther away from the internal os, the cervical stitch is less likely to perform as expected. So, in this particular case, we would like to know the history and then decide.
Okay. Sometimes the biometric contraction causes false image. Dr. Shamal. If there is a myometrial contraction, just wait patiently. Just wait patiently. Ask the patient to wait and re-examine the patient. Nothing else. I mean, you have to do the rescan once again. Dr. Prashant mention about site of the stitch after the insert clash. Please elaborate about it, sir. How to measure exactly? I mean, in terms of insert. See, Dr. Kiran. See, when there is a clutch, you can identify the site of clutch as a hyperechoic area which shows shadowing. Now, that area, how far off it is from the external loss, that is number one. How far off it is from the internal loss, that's number two. So, that's how you can identify the same. So, you need to mention, not, someone who is assessing the cervical length per se. It may be radiologist or anybody else. We need to identify the cervical encirclage site and the distance of cervical encirclage sites from the anatomical internal os and the external os per se. Dr. Prashant, is lap encirclage what is the best period to do it?
Best period. Ideally, it should be done before pregnancy, or it can be done in early pregnancy if the patient has come to us later.
Now, this is anonymous attendee. This is the best way to ask question. That's one of the reason why during all of my life, I never used to ask any question. If the patient refuses to do TVS, what should we mention in the report? We should measure or say that it is transabdominal ultrasound. Dr. Prashant.
Sir, that question you need to take because that counseling patients before sending for such NT scan or anomaly scan with counseling, it is my duty. But practically, when the patient has undergone an abdominal scan and now she's to be taken for a TVS scan, that time that particular counseling has to be done by their own.
So
And I hope
primarily,
but before sending such patients, first thing I would like to tell them that TVS is now a very scientific modality. Second thing, it doesn't cause miscarriage, it doesn't cause bleeding, it doesn't lead to preterm births. But by doing a good transvaginal scan, we would know what treatment has to be given, whether a surgical procedure would be required for her or no.
so I would put it in a different perspective, and that's the way in which I usually put it during most of my clinical talks. Unless and until, as a clinician, as an imaging person, I'm confident enough in saying that the transvaginal ultrasound is not going to harm my patient. If I believe that it is not going to harm, I can convince my patient that it is not going to harm. Am I correct, Dr. Prashant?
Yes, sir. Yes, sir.
Yes, that's. And after encerclage, at how much interval we need to follow the cervical length, Dr. Prashant?
Every few fortnightly, we usually follow them. And if required, if we find that the cervical length has decreased by 3 millimeters, then we would like to call the patient a bit early and do the surveillance again. If there is a decrease of more than 5 that means it is significant.
Dr. Prashant, because of you only, we are getting many questions to answer. And I think that is success of our program. I think uh, why what I usually tell in most of my imaging forum is that the quality of radiologist or imaging person entirely depend upon the question posed to him or her. If you don't ask more questions, the quality will not improve. Internos is close at 36 weeks. Shortening of cervical length appears 1 point. Individualistic questions, I usually typically don't answer at all. I mean, it has no relevance. Sometimes external loss is open. The bachelor's does not have any effect on. External loss is open. Dr. Vishal is asking. Dr.
External loss is
Prashant.
open. And what
Huh.
about the internal loss, sir?
Not mentioned. I mean, if external loss is open, what is the effect? That's what she is asking.
No, no, I would also like to know about the gestational age of the patient and about the internal loss. Then
So,
only we
so
can
it's an
recommend some.
individual case. I mean,
Yeah.
see, individual case cannot be
One,
asked in
one,
public forum.
yeah, yeah. And one more thing I would like to say, ki as the gestation increases, the cervical length also shortens. So when we
Yes.
say 25 so that is the fifth centile at 24 weeks. And suppose I have got a patient, first time she has come and I have sent for sonography and they say that the cervical length is 2 centimeter at 32 weeks. So I would not be panicked because I know that the patient is anyway going to progress and the patient may not land up into preterm labor. But definitely, I would tell the patient that see your cervical length measurement at this gestation age is 2 millimeters, 2 centimeters, sorry. But now what we are going to do is we are going to put you into surveillance and you need to again go and get the cervix assessed at 34 weeks.
Explain cervical elastography. I think that's at the experimental level. Um, still to do a great work on that. Sir, I want to know about Scholar MD. Scholar MD is a platform where the fetal medicine and gynecological imaging is taught to the radiologist fraternity. I believe the most of the gynecologists they know most of the things in fetal medicine and gynecology imaging. So it's primarily meant for you can Google and search for Scholar MD, and you will get the information regarding the same. It's a platform for radiologists more or less because those are the people who are deprived of clinical information on that. Sir, how is the access to the previous lectures? I mean, Dr. Shamal, you need to ask to the local Mindray guy. Neeraj Yadav, when should the encerclage stitch to be opened? When the encerclage stitch to be opened, Dr. Prashant?
Sir, we usually open the stitch at 37 weeks or prior if the patient has got come to us with pain in abdomen or in true labor. Then we need to open it at any gestation. But preferably, we open it at 37 weeks and wait for the natural labor.
Dr. Kavita Aneja. I mean, thank you, Dr. Kavita, for asking me question per se. She is a brilliant imaging person. I know her with name because she has done the Scholar MD with us, and she is exceptional as far as the imaging is concerned. Can cervical stitch be applied before pregnancy in previous history of incompetence? Dr. Prashant, thank you.
Yes.
It's not for me.
Yes, sir. It can be definitely given in patients who have got previous preterm losses. the cervical encerclage is done laparoscopically, and it has to be applied before the pregnancy, ideally. But even if the patient comes in the early first trimester, we can go ahead and do the cervical encerclage.
That's great. We are done with it. Thank you, Prashant, for being so patient in answering all the questions. Uh, Dr. John, Mr. John, are you around?
Yes, sir. Yes, sir. I was hearing your presentation and a lot of questions and answers.
Okay, okay.
This is
Thank
really,
you, thank you. I mean, we need to take a break for that. That no, no. I mean, we need to end somewhere down the line because it's almost 8:40 now. So thank you very much for
yes.
attending in such a great number. It's wonderful, Doctor. Thank you, Dr. Prashant Ingole, for showing such a wonderful gesture in replacing Dr. Mahesh Tandale, and it's really wonderful to hear your thoughts on everything from clinical perspective. I hope definitely you also have enjoyed the entire process
Yes,
of
sir. Yes, sir.
being associated with intraos and cervical length. I personally believe that unless and until we train our subsequent fraternity in terms of assessing the intraos and cervix, I personally believe something which is very basic. Most of the people in my department, they say, sir, internos and cervix kya hai? Internos is closed, cervical length is normal. That's by default. But that's not the true. We need to identify the significance of the same. So I hand over it to John to say your concluding remarks, please. Thank you, Don.
Thank you, sir.
Thank
And
you.
thank you, Aniruddha sir and Dr. Prashant sir. It is a great webinar actually in terms of the like internal loss as well as the CX assessment throughout the pregnancy. Actually, you also received a lot of questions and both the people and smiled and answers. That is really great, sir. And thank you very much. And sir, and most of the delegates also interested for the webinar, so that I will also share my contact number in the chat so that they can share the mobile number so that I will add into our WhatsApp group, sir, so that they will be getting all the information on time.
And John, please address those technical queries. I mean, so many people they ask for the previous sessions
Yes,
and
sir.
the
Yes, sir. I will
yeah,
collect the
yeah,
doctor's mobile number. I will share it with them, sir. Sure, sir.
I mean, just look into the matter and just address the same, please.
Sure, sir. I will do that, sir. Sure, sir. Thank you, sir.
Okay,
Thank
chalo,
you.
good
Thank
night.
you.
I hope you all have fun.
Yes, sir. Thank you. Thank you very much, sir.
Okay,
Thank you,
bye.
sir. Bye, bye, bye.
Bye,
Thank
bye.
you all.
Right, so the session is over, right?
Yes, yes, Vaibhav, and thank you all for your support. I'm just sharing my mobile number in the chat box. And hey, Vaibhav, and it's really great, Vaibhav. You also operated and still you are spending with us more than 2 hours. This is a really great, actually. Thank you, and you have to take care of your